Good morning, good afternoon, good evening, wherever you are listening to from whatever part of the world. We welcome you back here, myself, 𝐃𝐨𝐬𝐬 and Benoy Matthew, to Straight from the Hip. This is episode 4, which I will do an introduction on in just a moment. But Benoy, we've got a more important topic to discuss first off. We're 10 days into the new year. 2 questions.
Yeah.
1, are we exercising and losing our Christmas weight yet? 2, have you stuck to your New Year's resolution over the past 10 days?
Yeah. It's supposed to be, it's a Saturday here. So normally I go for a park run. I think listeners might know in the UK, I think it might be the same everywhere. So I'm a big fan of park run. I recommend to my patients. I was quite proud of, I did the park run on Christmas Day. I was in Birmingham. So me and my
Nice.
family, we did a park run. It was a very festive atmosphere. Everybody was sort of dressed up, and I did that. And then unfortunately after the Christmas meal and after that, everything has gone really wayside, I feel a bit sluggish. So it's just a good reminder for me to hopefully I can, plan to go to the gym today. And you think, people go back. It's a bit of a shock, isn't it? Going back to work, and then we're not in 35 degrees back in Perth, and the snow has really made things difficult. So so as physios, we give this message. So definitely get back. Now, how about you, Callum? You must be smashing it there with the great weather.
It's easier with the hot weather, but
Yeah.
I do have to blame my friends who sent us a massive box of British chocolate. Because I don't know if there's any Aussies listening to this, but if you go to the UK, the chocolate in Australia tastes different. It's not as good compared to the UK. And I'm sorry to badmouth it, but it is not as good. So our friends have sent us a huge box of chocolate, which my wife and I are slowly working our way through. So
Yeah.
I would still say I'm packing a little bit of extra weight. I'm in the gym training, but I would say the nutrition probably isn't quite back to where it is, but it's better than what it was at Christmas time. So we're in that transition. Phase, I would say.
And I think it's good to get back. And as I said, is getting back to what we don't want to be doing too much. I don't want to be doing what I say to patient. I don't want to be too much too soon, So I'm just easing into it.
That's fair. That's well clinically reasoned. Yeah, that's fine. Well, on to business. We mentioned this is episode 4. So we've spoken about in our previous episodes regarding FAI is the subjective signs and symptoms we covered, our objective clinical testing. Benoy, in our last session, we went into quite a lot of detail onto FAI mimickers, and we spent quite a lot of time on that. Today, we're talking about imaging, all the different types of imaging, when it's useful, is it useful at all? And if it is useful, when? Those are the questions we're trying to answer. And what is the best imaging modality to look at what type of pathology? I suppose what we're going to be covering. You and I started having a discussion before we came on air, and it's a question that I've been asked lots. And again, I've only been in Australia for 6 months, but I've been asked it in the last 6 months. What would be the key indicators that we would use for imaging? So if you've got someone coming into you with hip pain, what are some of the key things that make you want to image, that you think it's appropriate to refer someone to imaging?
Yeah, I think that's a great place to start is having some clear idea on the indications. So it's not going to be purely something you do routinely, because I feel without that sort of clinical context, it can lead to poor outcomes, because in many cases, the diagnosis is fairly straightforward and it doesn't really add on that. So let's go one by one. First thing, in my opinion, is potential red flags. So especially if you're working as a first contact practitioner or advanced practice role, the things I don't want to miss. So this is where the history is crucial. So things like cancer history, things like prostate cancer, breast cancer, they're more likely to metastasize. So if they have those sort of history and we think it could be potentially bony mets, we don't want to be delaying that. Systemic symptoms like fever, weight loss, recent trauma, things like bone stress potential, especially if you got a runner spiked up their volume, history of RED-S, history of previous bone stress. So those are the big ones not to miss. So number one, it has to be red flags, because that they can have disastrous effect on the long-term health and also could lead to poor outcomes. The second one is worsening symptoms. So you have a patient who comes in, things are starting well, but they're rapidly declining. They come in, they've been training, and then after 4 to 6 weeks, they are having night pain, they're limping, the exercise are not helping. They've tried painkillers, they've tried taking time off, but it's not responding. So this makes me slightly concerned is, why is that going downhill? Is it something intra-articular, which is sort of, or other thing which is worsening? So this is really important, because the patient also feels distrust that it's not going the way which we promised them or which we decided it should happen. Because generally, in 4 to 6 weeks, you must have some change. But if it's not going that way, then you might decide to investigate. Then the big one is diagnostic uncertainty. So if you look at the previous episodes, so there are some conditions, for example, like ischiofemoral impingement or proximal ITB, they can be quite tricky sometimes and they can overlap. The main thing with the hips is it overlaps quite a bit. So let's say you have a patient who comes with a young male, 32-year-old male who comes with groin pain, but he also has pain in the adductors and he also has pain on the pubic region. So you're thinking, oh, is it adductor-related groin pain or is it hip impingement or is it osteitis pubis? So you can have a mixture of everything. And this is where it's a problem is there's this overlap features clinically, and then you might want imaging to have a bit of diagnostic certainty, especially when a patient feeling that they're not improving as well. And the last one here is pre-referral requirements. So in some settings, for example, the setting I work in, if I'm going to send somebody for a second opinion to orthopedics, they'll always want me to do the pre-workup, which could be an X-ray or MRI. It could be the same in private. If you're going to send somebody as part of the workup, you might want to, for an opinion, you might want to do a workup. But the big ones, in my opinion, are red flags, worsening symptoms, and diagnostic uncertainty. So that is what drives me on that. But clinically, it's always important reason why you're doing it. For me, it always comes back to the two questions is, what is my working hypothesis and what's the best modality to help me to answer that question? So it's always going back to those two questions is what I'm thinking and or what I'm concerned about and what's the best modality for that. So hopefully that sets the scene.
Yeah, no, perfect. And the other thing that we discussed was imaging safe. So I think that's sometimes a concern for patients. Depends
Yes.
on the demographic. And I might ask you a specific question in a second, Benoy, if that's all right. But is imaging safe for us to be using? Because there's a lot of discussions, particularly around spinal pain or lower back pain, where imaging gets used far, far less. And that's spoken about a lot. And is it going to lead to catastrophization if we scan someone? Is it radiologically safe for the patient? What are your thoughts around that, just very generalistically?
Yeah. So I think that radiology-wise, we know, like with especially anybody in a reproductive age, especially females, or more even men, like in that sort of 20s, 30s, we don't want to be exposing them to things like X-rays because that around the pelvis region, we don't want to be doing multiple X-rays. But having said that, when I refer them for a second opinion, usually many of them will having CT scans, which are having much more radiation than an X-ray. So sometimes it's necessary for that. As therapists, we are very cautious, which is rightly the way to do because we don't want to expose them. So I'm always thinking, is it really necessary? And checking with them. People have done the IRMA training, especially if you're FCP, you have to screen, are they pregnant or it's a chance they could be pregnant to making sure they're safe. But the big one, which you've sort of opened up, the big elephant in the room is the narrative I'm seeing all over is it too much imaging or is it more how imaging is used? So I think when you look at most of the back research, we know that excess early imaging is harmful. There's some good studies there. But can we use that for the whole rest of the body? And the truth here is it's not really the imaging itself, it's that reasoning, the interpretation and the communication, which was really important. And when you look at from your biopsychosocial approach, imaging is never meant to be the whole story. It's just one component of your diagnostic reasoning, and it should be anchored in clinical findings. So in my honest opinion, if imaging is used appropriately with good history and examination, it can only lead to clarity and reduce diagnostic error. And areas like the hip and groin. So I'll just give you one example. So I think for 3 to 4 years, I did, we have a system, like a good sort of working system in Guy's Hospital. We call it the Integrated Back Clinic. So it's me, and then there's a band 6, band 7. So we do multiple cases together. So we go through at least 15 to 16 cases in that half a day session. And I have to keep track of all the imaging. So I have all my Excel sheet of all the scans I have to refer. Usually it's MRI. The main reason I refer in the back clinic is previous history of cancer, suspected, cord compression, things like that, stenosis. And if it's 𝐾𝐸𝐤𝐬, now obviously I'll send them straight to A&E. So when I looked at my records for the last 4 years, less than 5% of my back patients, so I must have seen at least 800 to 1,000 or maybe more, less than 5% needed scans. Most of them don't need scan, no need X-ray. But the problem is I can't use that for back. When I look at my logbook for hip scans, it's more likely to be 40 to 60%. It's nearly 10 times more. It's because the diagnostic uncertainty is very high in hips, and I'm dealing with hip. So using the same model as hip, unfortunately, is not going to work in complex areas like the hip. I think we need to move on, like not saying like imaging is bad, but let's use it smarter. Knowing when to use it, how to integrate it, and when to get a second opinion is really important. So I think, especially for junior physios and the people on the social media, this is a common message I'm hearing. So what would you say, Callum, on that?
Yeah, again, on social media especially, that's the message that gets driven home a lot. And I think a lot of the examples are neck pain, lower back pain, spinal pain, and the biopsychosocial model and why imaging isn't necessary for low back pain. Completely agree with all of it. I don't disagree with all of those messages that are put out there. And I would say that when I was in my FCP clinic, yeah, I couldn't give you exact percentages. I didn't dive into and actually assess the years that I was in FCP in terms of a logging, but I wasn't sending people for scans for lower back pain. It was a very, very rare occurrence. And that certainly reflects with what the research says, isn't it? That we know that 95, 98% of the time, nothing sinister is going to be going on with someone's back pain. And I think, as you said, 𝐃𝐨𝐬𝐢𝐬, metastases, cancer, those are the things you want to rule out. But my concern with newer grad or early years physiotherapists or musculoskeletal professionals is that, are they going to carry that concept for the rest of the entire, the rest of the body, and think for a hip, for a shoulder even, I know this isn't a shoulder podcast, but in the sense of the hip, we don't need to image, we don't need to scan. I'll treat it exactly the same as the lower back. Are we then training younger practitioners to become unsafe?
Yes.
That's, I suppose, my concern.
Yeah. And I think it's a different areas, and people will say, "Oh, does a label make a difference?" And it does make a difference. If it's a bone stress, if it's AVN, it does make a massive difference. And we know that people with severe grade bone stress can take even 2 years, 1 to 2 years to go back, and that is a huge timelines for. So, for example, one of the things is if you catch a bone stress at grade 2, then a full bone fracture, that could be 1 year difference in rehab. That's a massive difference. So, and for a patient, it's devastating. Like if you say to somebody who's runs a lot that you can't run for 12 to 15 months because you missed it, that's something I don't want to be doing that. So, and again, most of the time, even with my experience, whenever I refer, I think in the previous episode, I said about a case where there've been 2 female runners who came to me before Christmas, classical case of bone stress, slim, BMI less than 19, previous bone stress, bit of acute irritable hip. And I said to them, like, I think I'm not too happy to continue with running unless we get an MRI. I'm thinking you got a bone stress. But both of them came back with a negative, which was fantastic news, but it came with FA syndrome. So obviously imaging, I did think it was bone stress, but I was clearly not right there. And I'm happy I'm not right there, because there's no way to differentiate in an acute irritable hip. So it's being very honest to the patient. So I always say to my patient, this is my concern and I don't want to miss it. I could be wrong. And people totally appreciate that honesty. I don't have X-ray eyes to look whether it's a bone stress or things like that. So don't put pressure on yourself when you refer for scan. Is you explain your reasoning to the patient, tell them this is what you're concerned about. It could be other things happening. And people are totally fine with that.
I think it comes back to one of your points when I asked you when would you use imaging, and what you've alluded to there is diagnostic uncertainty. You just didn't know. And then you're thinking, well, if I don't know, how can I ensure that we're being safe here? That these people coming to see me under my care, I can't be certain that they are safe. So we'll get the MRI. And sometimes it's great to be wrong. I think as physios, I think we said this at the end of our last podcast, is that we put a lot of pressure on ourselves to be right first or second time. Sometimes we're never right. And sometimes, like that example, it's fantastic not to be right, because at least I did the scan, I could reason it very well. And it comes back to it. As long as you're referring for a scan and you've got very good clinical reasoning behind it, imaging is absolutely fine. I think it's when you haven't got good clinical reasoning, you haven't considered all the other factors, and you're just sending someone for imaging routinely. That's not a good practitioner. But that's a good example you gave there, Benoy, of what makes a good practitioner for those 2 cases, those 2 runners. Yeah. Also, X-rays. I think that's the one that we're going to start on. So X-rays for hip impingement. I think you may have said either in this podcast or last one that if you're in your NHS setting, often you do refer for an X-ray straight away, because that's just part of the protocol. Whereas in private, you'll often go down the MRI route. So in either scenario, when do you utilize X-ray for hip impingement, and what sort of things would you be looking for on an X-ray?
Yeah. So I think there's this general concept. Even I fell into the trap when I went to hippies. There's the feeling X-ray is a bit outdated. It's a bit old-fashioned. MRI is more, more posh, sexy sort of thing. And this a big light moment for me. Where I was sitting in the 𝐂𝐸𝐬𝐬 clinic. Is one of the leading surgeons, and I think it was in 40 years of UCL. So most of the patients were coming with an MRI report. And he didn't even look at the MRI report. He spent a good 10-15 minutes looking at the X-ray in detail. So he obviously took a thorough history. It was a sort of a big moment for me to realize that how much importance X-rays is given by the leading hip surgeons. And that sort of really helped me to give the importance. So for me, and based on the literature, X-ray is the primary modality for morphology. So if you're thinking of anything intra-articular, and it's morphology based. So we're thinking of cam morphology, pincer morphology, hip dysplasia, retroversion, osseous stabili, early osteoarthritis, things like that. Then, we don't have to jump straight to an MRI. But the main thing with the X-ray is getting the right views. So when we look at morphology in conditions like hip impingement, an AP view alone is not sufficient. We would definitely want a lateral view. So when I refer in the NHS setting, I'll ask for an AP pelvis and a lateral view. If you look at the literature, the best view of the lateral view is something called a 45-degree done. I've tried it many times. Sometimes I'm lucky I get that view, but any lateral is better than no lateral. So if you don't get the 45-degree done, then don't feel disheartened. At least you'll get more information from a lateral view. And sometimes those cams can only be seen on a lateral view. And then, so first thing is making sure that you have that clear thinking it's intra-articular, and then making sure that you get the right view. And the most important is you only ask what you get for. So if you're not very clear in your referral, for example, I'll say, young active male, active related groin pain for more than 8 months, suspected hip impingement, please comment on alpha angle and lateral central angle and the acetabular index. Then you're more likely to guide the radiographer or the radiologist of what you're looking for. So we don't want to go too technical, but there are a few points to be relevant here. For example, there's something called the alpha angle, which tells you how big the cam is. So anything less than 60 degrees is considered to be normal. Anything more than 60 degrees is considered to be a cam morphology. Whereas if you look some of the old American papers, they use 50 degrees, which is a bit, I think, if you put 50 degrees, everybody will be having cam, in my opinion. Whereas 60 degrees is better. A lot of research later has said 60 degrees is more a reasonable cutoff. And the lateral center edge angle tells you the coverage of the acetabulum. So generally, it's between 25 to 39 degrees. Anything more than 40 degrees is a pincer. Anything less than 20 is dysplastic. And there's also other conditions called acetabular index. So there are a few technicals. So the key message here is communicate very clearly what view you want and request the radiologist to comment on the cam, pincer, or dysplastic. Even if you don't know the angle, you can say, please comment on cam or pincer morphology or dysplasia. Then you're more likely to get a reasonable and a more request. A big problem in primary care, especially in FCP practice, is unfortunately you don't see the images. So the images will come back and saying it's normal. So I see this all the time. So patients had a report say nothing, no fractures, nothing normal. And then you look at this, there's an obvious dysplastic hip or an obvious large cam. So I don't know what's the solution around it, especially if you don't have access to images, but always, trust the patient. The MRIs and the X-rays don't always pick it up or not reported. They pick it up, but it's not reported, and get a second opinion. So there's a lot of issues I feel on the system and also being reported where people have 4 or 5 X-rays, but they've all been told it's normal. So key point here is bone morphology, clear views, and be clear on what to ask for.
Yeah, I think you've touched on a good point there, Benoy. And I know we're going to talk about hip dysplasia in much, much, much more detail in later podcasts. And I think what you've said there, the reporting, radiological reporting, underreporting, same with FII, where things come back as quote unquote normal, but then you notice actually they're not normal. And I think what you're describing there is making sure that we are remembering the hip is 3D, it's not 2D. So not just asking for that AP, we need that lateral view done if we can. Just for people that don't know what a done view is, are you able to explain what that is so that people know?
So basically, when you look at the 45-degree done, it's the position where they are, having that sort of view is a specific X-ray technique where the patient is supine, the hip is flexed at 45 degree. That's why it's called the 45 degree, and it's abducted at 20 degrees, and it's a neutral rotation. So it's the preferred method and the most evidence-based method for evaluating cam morphology. as that. So patient supine, flex at 45 degrees, that's why it's 45 degrees, and abducted 20 degrees, and no rotation. That's basically 45-degree done. Obviously, there's other lateral views like the frog lateral, but every radiology department will have their own sort of lateral views. So sometimes I say beggars can't be choosers. I'll go with I'll go with anything what you give me. So I say please give me some lateral. So many times I used to be very insistent, and many places I didn't get that. Then people used to reject my referrals, and then I don't antagonize my radiology colleagues. I know they're under a lot of pressure, so I'll say if possible 45-degree done or any lateral. So that's still good on that. It doesn't have to be the gold standard, but lateral view is definitely mandatory, especially with that. But on the flip side, let's say you're dealing with like a 58-year-old male or female with an obvious hip OA. We don't have to put them through all this lateral views. It's hip OA. Just the standard AP pelvis is more than enough. So if you've got an elderly patient, why do you want to give them an extra X-ray and extra radiation? So I get this. I don't know whether you get this. I get like a 70-year-old X-ray, and people say, "Do you think there's a cam here?" And I say, "So what? Is that going to change anything? Is it dysplastic?" So I think we have to be careful not to over look at, especially I tend to use the age cutoff as 40, 45. So after 45, I'm not really interested in cam, pincer, dysplasia, retro. Is it OA? Is it not OA? That's it. Keep it nice and simple in that sort of middle age, later years, because if you got a bit of a large cam when you're 52, is that going to do anything? You just treat them as an OA. Do you find that is overreported in that elderly group as well, isn't it?
Oh God, yeah, definitely. And I think that cut off of 40, 45, I think that's a nice cut off, because as you said, look, you could look at that and say, okay, they've got a cam, but the cam could have been what led to the OA. Does that cam? That's not going to change anything. We've got hip osteoarthritis, yes or no, and I think it all comes back to the clinical reasoning, not just aimlessly imaging.
Yeah.
We know hip osteoarthritis is much more of a clinical diagnosis now than a radiological one. If you feel that person is appropriate for an X-ray, fine. But as you say, I think an AP pelvis would be absolutely okay. Does it change the management? No. Something that I wanted to ask you, Benoy, we did a course together a year or so ago, a hip course. And when we broke off for a break, I had a couple of people come up to me and say, I feel a little bit nervous about asking for requesting imaging. I feel a little bit nervous to say, can you give me an AP? Can you give me a lateral center edge angle? Can you give me an acetabular index? They felt as though they were stepping on the radiological's toes or the orthopedic's toes and worrying that they were going to ruin relationships. What would you say on that?
Yeah, I think obviously, the thing with the radiologists is, I've sat through many lectures, is radiologists love when you have a clear reasoning in your referral. They want to know your reasoning process rather than saying, "Oh, patient got hip pain, please X-ray the hip." It doesn't really. It's like if somebody comes with a knee meniscal pathology. What are you going to say when you do an MRI report? Is medial knee pain, trauma, clicking, catching, positive meniscal test. Please, rule out meniscus. So it's the same reasoning here. First is having the clinical contacts and saying, young active patient, likely hip impingement. I don't say they got hip impingement. I always use the word likely hip impingement symptoms. Would benefit. I will always use the word would benefit. Would benefit from AP and lateral view. Obviously, be polite. Please. So we're not going to be professionals, and we know everybody is under a lot of strain. So if you put the reasoning and explain your sort of clinical reasoning behind it and make a request, 8 or 9 out of 10 you'll get. And even sometimes I don't get that. Sometimes I work in centers where despite my request, it gets rejected and say, no, we don't do. Our policy is, for example, I had this one, I was doing a locum where this policy was, we'll only do lateral views for consultants. It's not for physios. So sometimes I just have to accept that, So that's local protocol here. But all we can do is be very clear, be polite, and hope in the interest of the patient, they do it for you, So there's a lot of local variation in the NHS and private. I'm sure it's everywhere across the world, But the more we talk about it, the more we raise the awareness, is best for the patient.
Yeah, and I would echo what I said to these 2 physios that spoke to me, was that I've never had any pushback. And I think a lot of it is down to just being polite, being inclusive, just saying, please, could you assist? I'm considering this. Would you mind having a look at this for me? It's just being inclusive. And as long as you're polite and professional, you shouldn't get any pushback by being specific.
Yeah.
in your referrals. It leads us on to MRIs. We spoke about X-rays. MRI, as you said, is the nice sexy bit of kit, the most expensive piece of kit that we use. Do you prioritize MRI over X-ray in certain instances related to FAI or others?
Yeah, definitely. MRI is a great choice for soft tissues and suspected red flags. So if you think of involvement of the bone stress, the labrum, the cartilage, cancer history. So for example, if you got, a middle-aged female who comes to you with suspected GTPS, but she had, breast cancer like 5 or 8 years ago, worsening night pain, then you don't want to miss bony mets from that, because that's always a concern. So things like cancer history, bony stress, I would skip, especially in private. I would skip the X-ray. I'll go straight to an MR, because my reasoning here is the red flag pathology. And other side is when they got very irritable hip, do they have synovitis? Do they have reactive bone marrow edema? So if you have a young athlete, so that let's give you 2 scenarios. So if you have a young athlete, hip pain, limping, suspected bone stress, I would go straight for an MRI. X-ray can mix those sort of early bone stress. On the other side would be somebody with a previous cancer history, then definitely it has to be going to the MRI to make sure that we are not missing metastasis. So soft tissue, red flags, bone stress, your imaging choice will be MR.
I don't think we need to add too much to that. But that's quite clear cut, that one. One that I know you do a huge amount of, Benoy, is ultrasound. And this one probably isn't quite so clear cut in when you're using it and when you don't. I know that ultrasound has got much greater benefits for certain pathologies than others. As you're the practitioner that does this on a daily basis, where does the role of ultrasound sit within your hip assessments? Does it sit with FAI specifically, or is it for other things?
Yeah. So when you talk about ultrasound, I've been doing it for about 5-6 years. So I used to, before I got trained, I was a bit skeptical of the whole ultrasound, because I thought the X-ray and MRI was more than adequate with my reasoning. But again, what I picked up is I used to think the X-rays and MRIs will pick up everything. And that's the thing with, as you get more experience, you understand we all have blind spots, and all imaging has those sort of blind spots. So let me give you 2 scenarios where I was sort of misled by those X-rays and MRI. One was the one I see quite a lot is meralgesia paresthetica. So you have this burning pain around the ASIs, usually people with high BMI. And generally, this tends not to be reported on MRI or even nerve connection studies. So there's also other conditions like proximal ITB. I had quite a few people, runners with proximal ITB syndrome, where they had MRIs, and obviously it won't be seen on X-ray anyway, but even MRI misses that. So when you talk about the strength of ultrasound, there are a couple of things. It's great for real-time imaging, so you can really move them, see how they're moving to see for any fluid, and it's fantastic for soft tissue and especially superficial structures. So let's go some of the key conditions. So things like GTPS, tendinopathies, bursitis, proximal ITB syndrome. I use a lot for adductor tendon pain as well, so I can see for thickening of the adductor longus, nerve entrapment of meralgesia paresthetica. And the main limitation here is it's hugely operator dependent. So I think if there might be some of you who might be training, especially in the UK and other places, on ultrasound, and I did a podcast with the ultrasound side guys. It's called, I think it's just MSK ultrasound, and it's a fairly long podcast where I go through my journey of that. And for somebody who I thought, I think I'm decent with my hips, and before I start my ultrasound, I thought it will be it will be quite easy for me because I know the anatomy, I know the morphology, I know my X-rays, MRI. I was really humbled how difficult it is to ultrasound the hip. It's one of the most hardest areas. Most people start with shoulder and knees. And I think for me, it took me 3 to 4 years to be really confident with the hips. It's very deep. It's quite, you need a bit of skill. So it's not really for someone unless they spend a lot of time. So it's a tough skill to pick up, but the reward is endless because you're doing in real time. And also the final point with ultrasound here is it's great for people who are doing intervention. So I find the biggest benefit of ultrasound is to give guided injection for diagnosis. So a lot of times you're really not sure, and you can give a simple lidocaine and injection on the same sitting, do the provocative test, and the pain is gone. Then one of the best tests to prove whether it's intra-articular is diagnostic hip injection, which is done through ultrasound guidance. So big benefit. So fairly straightforward in trained hands, but highly operator dependent. But things like superficial tendons, proximal ITB, adductors, malleolus parasthetica, it's the imaging of choice. And more physios. I don't know about Australia, but in the UK, in the last 2 to 3 years, there's been a real boom in ultrasound. I get messages all the time, people asking, how can I get trained? There's more and more physios, and I think it's great for therapists, and that is slowly changing. And I'm sure even in Australia and other places, it'll only happen, because I think it's a fantastic tool for MSK therapists. And for me, it's like a stethoscope. It's a part of my objective, and it makes our job easier in many respects.
Yeah, I would agree, but having worked obviously all of my career so far in the UK, if I do come back to the UK, I think ultrasound will be something I'm definitely going to be pursuing, because it was something that I had a play with during my master's degree at Queen Mary, and I had a little bit of a play with it afterwards. The hip is a minefield. As much as I like to think I'm good with my anatomy, I understand the morphology, imaging, etc., everything you've just described there, and then I put the probe on to someone's groin, absolute minefield.
Yeah, it's a...
Whereas with the shoulder, it felt a little bit easier. The elbow, the knee, the lateral ankle, all felt a little bit easier.
Yeah.
But yeah, the hip, very, very challenging indeed. So I think it's a great skill that physios are starting to utilize, are starting to get trained in. We don't have it available here in Australia. It's not part of physiotherapy scope of practice just yet, but I can see it going in that direction, because I think it's a fantastic tool to have, especially because it provides things to you in real time that you just alluded to.
Yeah.
What you also mentioned was the diagnostic injection, which leads us on brilliantly to that next point. Here in Australia, I have to refer for diagnostic injections to generally it's sports medicine physicians. If not, then it will be an orthopedic consultant. Now, I've had a young lady recently that's got a left side hip dysplasia. So it was a concern of mine. So I think she's presenting with dysplasia. We got the imaging, looked at the morphology. Everything matches up, if you like, in the morphology presents as a hip dysplasia. It's looking like she's going to go down the route of a PAO, but I referred her to the orthopedic consultant that referred her to me, asking, I think we would benefit here from a diagnostic injection, which she went and had. It proved that the pain was coming from the joint itself. But I think there may be a lot of practitioners out there that aren't aware of diagnostic injections, don't know how they work, when would you use them? Could you elaborate a little bit more on that?
Yeah, that's massive. I think that's a real game changer in the diagnosis, because the problem with imaging, especially MRI, is it's very common. Like, I think if you look at the previous episodes, like 1 in 4 people will have those normal variations like cam and pincer, and 3 in 4 active people. So extremely common. If you've been active from the age of 8 to 20, you pretty much, it's a given you're going to have some form of impingement, or if you come from hypermobile background to have dysplasia. So we should be careful not to jump and label them with pathology, because this is a quite normal phenomenon. And also, in many cases, people will have multiple pain generators. So they might have an adductor pathology, GTPS, along with the dysplasic, or they can concurrently happen. So the only modality which can help you to differentiate clinically is injections, to differentiate between intra-articular versus extra-articular pain. So there are 2 benefits of injection. One benefit here is diagnostic. So if you, like the case you mentioned, Callum, when you have uncertainty about your pain source, and we don't want to go into big surgery like PAO, which is one of the biggest surgery. We want to be 100%, not 100%, at least 99% sure that it's the right source of pain. Diagnostic injection is the most valuable adjunct. So one is to make sure, usually they'll just give a long-acting lidocaine, or bupivacaine or local anesthetic, and then see the response, and they have a big effect. The other big one, which is not well known among many therapists, is it's fantastic for calming down an irritable hip like an FAA, and to avoid surgery. So let's say you have a patient with FAA syndrome, and they come to me for a second opinion. They can't sit for 15 minutes. They're waking 3 times at night. They've tried naproxen. Nothing is happening. And do you think I can fix them? There's nothing magical I can do for them, the pain to go away, because they've tried everything. I'll say to them, I can't really do much here. Why don't you, in the private, I've got 2, 3, in the NHS, I do it myself, but the private setting, because it's covered by the insurance, so it's much more easier for the patient. So I refer to a couple of well-trusted colleagues. They have steroid plus a local anesthetic, and takes the pain away. I ask them to take it easy for 2 weeks, get them in the pool. And when we talk about the management in the future, it's a great tool for people where they're struggling with high irritability. So therapeutic injection guided is also useful. So definitely, guys, if you're in hip and groin, try to link up with your network find somebody locally who can give you both diagnostic and therapeutic, and that will be a big game changer in your rehab, and also being sure when to refer them for surgery. And also, in many cases, having the injection will calm down the hip. So the analogy I use is something like frozen shoulder. So if you got somebody with an irritable shoulder, what you would do is get the steroid and then rehab them. So for me, it's the same thing. So get them really desensitized, and then we can avoid surgery. And once you have an injection, generally you're given 3 months before. Generally, they don't operate for 3 months for hip scopes because of risk of infection. So you have a solid 3 months really. And if you can avoid surgery, that's a fantastic for everyone.
Yeah, I think that's a really good point, because I think like imaging, where, we shouldn't be injecting, because again, there's a lot of research that on the negative side effects that injections have, or, when we're comparing like rotator cuff pathology, are injections better than placebo versus there's a lot of talk around that, but injections like imaging is not a dirty word. They definitely have their place. And I think you've highlighted a very important one there, Benoy, that it can help to ease symptoms up, to avoid surgery, or to help your rehab. So no, that's a very, very good point. We'll go through a bit of a summary and chip in, Benoy, if there's anything that I'm missing on everything that you've said there.
Can I just add one thing before? Yeah, one area is, even with all the stuff I do, is when I refer for a second opinion. So I work with Kristen Smith at Guy. So when I refer them for, so I've done the X-ray, I've done the MRI, maybe they had injection, they're not improving, and possibly like a severe dysplastic, they need surgery. Most of the time, or nearly all of the time, they'll do even further investigation tests. So they might do a CT scan, they might do a 3D anatomical assessment, and that will help them to understand the complex morphology. And you rightly mentioned recently that it's a 3D anatomy, it's not like a 2-dimensional. So you need a 3-dimensional CT scan to look at, and sometimes they might look at the whole limb as well. They look at tibial torsion, angulation, the assessment of that. So there's a lot more to that. Obviously, it's not my scope of practice, but this is just to give you an idea how complex it is, So it's just not simple X-ray alone. You'll have to get the X-ray, the MRI, but we don't have to get involved in that. It's just to know, or maybe inform the patient, is the consultant will do a lot more than what a physio would do. And they're not going to rush into a major surgery like PAO or a hip scope unless they are very clear. And they'll also include the diagnostic injection as well. So there's a lot of testing, and that might take 3 to 5 months before they get everything information. So you have to be patient. It's not like simple, oh, I went and had an MRI, I've got labral tear, I need surgery. It's a very simplistic way of looking on that, isn't it? So people have to realize that it's a very complicated decision, and the best decision is always done as a team. So you're going to work with the radiologist, the sports doctors, the orthopedic surgeon. We all agree that it's the best thing for the patient with the combination of all the information. So that's why sitting in MDT meetings, or even working with that sort of environment, massively improves our reasoning to help us to decide on that. So, but again, it's not a physioremed, but I thought that'll be useful for people to know.
Yeah, and it's, as you said, it's good clinical reasoning, it's safe practice. The examples that you've used there as well, the only side bit I would echo to people is that the kind of stuff that Benoy has just been talking about there, that I suppose is when you're looking more at surgical planning, or thinking about, is there a surgical target here? I don't want, because I get asked this a lot when I do just little bits of CBD for people, do we need a 3D CT for everyone that we think has got FAI or hip dysplasia? No, you don't need it. Yeah. To be honest, if you send it to a good consultant, an X-ray can be more than enough. If you're looking at 3D morphology, things like that, that's if we're looking at surgical planning. So don't feel as though that you need to look at all of this for every single patient. It all comes back to who you're dealing with, what's the reason behind it, what is the target that we're going for. Would you agree?
Yeah, and definitely see, like the rehab point of view, let's say if you have somebody with a cam and a pincer and a retroversion, do you think your management is going to be like so much different? Because for me, when I do the rehab, I keep it simple. Is it impingement morphology? Is it instability morphology? Is it OA morphology? That's it. So it's great to talk about alpha angle, acetabular index, but am I going to give them any different exercises or different advice? Not really. So sometimes we can be burdened and overwhelmed with too much of information from a rehab. So that's why sometimes you can't dumb it too much as well. Sometimes you have to simplify as well. So it's simplifying in the rehab is important, but the radiology is more information, as you rightly mentioned, surgical planning. So I don't make any big difference in my rehab, whether they have a little bit of retroversion or on that. I just go with the clinical presentation. So as physios, sometimes that extra information doesn't really help. In fact, it can create more complexities and confusion. So, and I'm not going to do the surgery. It's the surgeons to decide how much is the angle, what is that whole lower limb. But it's good to discuss that with the patient so the patient knows what's part of the journey. So they are well prepared that it's not something which is rushed. And it's a hallmark of a good surgeon that they don't rush into it. They're going to take the time. They're going to get all the right scans. They're going to read what the physio has given in the report, see the progression. They're going to see the response to the injection, and then the surgeon has all the information they need to have a honest conversation with the patient to discuss the pros and cons of the surgery. So it's a slow process. It's not like an avian or a bone stress where you have to decide straight away. So things like hip impingement and hip dysplasia, I think they're well within the time to have that time to not to rush into surgery. And the patient also feels confident that they are in safe hands.
Yeah. And I think just to summarize that little bit that you said there, but I think keeping the rehab simple is all. We'll talk about rehab. We're early in our podcast here. We'll talk about rehab, but keeping that simple, the understanding of morphology, the understanding of imaging, the understanding of surgical procedures. Yes, we're not the ones doing it. Yes, it doesn't influence massively our rehab or what we're going to do. But I think it's important to have an understanding of all of that, because then you and I can have discussions. We can have discussions with other physios. We can have those discussions with surgeons and radiologists, because it shows that you know your stuff. But is it going to be relevant to the patient? Not always, no. Not with the rehab, in a rehab context.
Definitely. Yeah.
So if we touch on those three sets of scans, where we looked at X-rays, Benoy, you said that an AP view wouldn't be enough. Ideally, you would want a lateral view. Whether it's a done view, fantastic if you can get that. But you said if you can't get that, you're not too worried. It's making sure you're getting an AP and you're getting a lateral view of someone's hip. So you're getting a much better understanding of their 3D morphology. And you also said that the communication needs to be very specific. Don't be afraid to put in your referral exactly what you're asking for, very politely, very professionally, to the radiology team. You said the alpha angle, 60 degrees, is about normal.
Yes.
A lateral center edge angle of around 25 to 39 degrees is also normal. If the lateral center edge angle is over 40 degrees, then it's high likely we're looking at a pincer type FAI morphology. If it's under 20 degrees, then we're looking at a form of hip dysplasia. With MRI, it was quite a bit more straightforward. It's for the diagnosis of what's causing that person's hip pain. Ultrasound, you find, is very valuable for soft tissue as well. So any of your tendinopathies, any of your bursas, but you also said nerve pathology, like neuralgia paresthetica, which we'll talk about, I'm sure, another time. So any nerve-related condition, you said ultrasound can pick up very, very well. It provides real-time assessment, and it's something that if you're trained in, you can be doing injections at the same time as running your diagnostics with the imaging as well. And the diagnostic injection, you said, can be a great problem solver to find out if that person's hip pain is intra-articular versus extra-articular, but it can also be very helpful in reducing that person's pain if you're trying to avoid surgery, if you're really trying to push this as a conservative target. And the final bit, which actually I think is your message, Benoy, which I'd be happy for you to elaborate on, is that it is okay to use imaging. Imaging is not a dirty word. It is safe to do it. Imaging is not the whole story.
Yeah.
But I'll let you take hold of that.
Yeah, it's imaging smarter. And I think what we want is choose your modality based on your clinical question, So you're getting the right views. And remember, imaging is only as effective as the clinical reasoning that guides its use. And, we can't use the back model with the hip. And for patients, especially when you're dealing with the sort of high performance and you're more likely to see things like bone stress, the quick intervention can mean a big difference in the return to running and play like that. So a setting will make a big difference. So it's all about the setting. It's the clinical reasoning. The right investigation can only give you clarity and reduce diagnostic error, which is all we all agree that's great for the patients. And the hips is, I would say, the hip and groin is one of the most challenging areas where there's a major limitation for clinical testing. So the clinical testings are, more for having that sensitivity, but you can't really be sure of that. So this is where the imaging becomes more important in this area. But again, one last point I would say is please build up your network here, so try to have good links with sports doctors who have interest in this. There's a lot in London, and also make sure that, you are having the discussion with the radiologist, because it's difficult on your own, especially if you're in private practice. So that's why linking up with the right people will make the job much more easier rather than trying to figure it all on your own.
Try to be a superhero. No, that's brilliant. Really good conversation, but I've enjoyed that one. And I hope that our listeners appreciate it a little bit longer. But I think this, just like our FEI mimickers in our previous episode, is a very, very important topic that I think warrants a little bit more time and attention to. So if you have managed to stay on and listen to me and Benoy bang on for this long, fair play to you. Thank you very much for listening and for joining in with us. And we look forward to welcoming you onto our next episode. So we'll see you very soon.